Heartburn and dyspepsia. Case. Dear Dr. Mr. Ben Harrison, aged 68 years. This man has had retrosternal burning pain for many years, usually helped by over-the-counter antacids. However, in the last 6 months his pain has been more troublesome and sometimes unresponsive to the antacids, and he has also developed upper abdominal discomfort. Has he developed a peptic ulcer, or is something else responsible for his dyspepsia? Yours sincerely. Introduction. Dyspepsia is an unpleasant sensation in the upper abdomen. If new, it is an alarm symptoms in patients over the age of 45 years and requires rapid investigation because of the obvious concern that it is due to a carcinoma of the stomach. The most common cause is inflammation or ulceration of the upper gastrointestinal tract. Other causes are listed in Table 1. It is important to remember that pain or discomfort in the upper abdomen can come from many sources, e.g. gallbladder and pancreas, and therefore a careful history is essential. Upper abdominal symptoms may also be referred from above the diaphragm, although this is unusual. Young patients, younger than 45 years, are unlikely to have malignant disease and can therefore be investigated non-invasively. History of the presenting problem. Pain. Dyspepsia pain is most frequently felt in the epigastric region. Ask about the following. Duration. Dyspepsia lasting for longer than 6 months is likely to be of benign origin. Radiation. Pain going through to the back is suggestive of a duodenal ulcer or a pancreatic cause. Pain radiating to the right upper quadrant or shoulder tip may indicate a biliary cause. Relieving or precipitating factors. Gastric ulcer pain is typically worst on eating, whereas duodenal ulceration is worst between meals and relieved by food. Biliary pain may be stimulated by fatty foods. Ischemic intestinal pain usually occurs as food passes down the small bowel and arises sometime after a meal. Does the pain come on during activity? It seems unlikely in this case, but angina can sometimes present as upper abdominal pain. Nocturnal pain. Functional disorders very rarely cause disruption of sleep. Other symptoms. Key issues to ask about include the following. Vomiting may indicate obstruction. The nature of the vomitus is important. Gastric outlet obstruction leads to regurgitation of undigested food, sometimes many hours after it was ingested. Hematmesis clearly suggests peptic ulceration. Reflux of an acid taste into the mouth suggests hiatus hernia. Smoking and alcohol history along with caffeine intake are important in those with reflux symptoms as they represent potentially beneficial lifestyle modifications. Early satiety, a significant symptom associated with gastric cancer and therefore needs investigation, but can occur in benign as well as malignant disease. Some patients with peptic ulceration get pain or discomfort on eating, which leads them to stop, and early satiety can also be a feature of functional dyspepsia. Abdominal distension or bloating may suggest a functional cause. Change in bowel habit. Melena would indicate the possibility of peptic ulceration, but also neoplasia. Diarrhea may suggest malabsorption such as found in chronic pancreatitis, which commonly causes pale stools that float, difficult to flush away, or are fatty or oily. Steatorrhea, in addition to epigastric pain. Weight loss, how much and over how long? Significant loss of weight increases the likelihood of significant pathology but can also occur with benign disease, in particular if eating causes pain and induces the patient to reduce intake. NB. Dyspepsia with weight loss necessitates urgent investigation to rule out gastric cancer. Episodes of jaundice, dark urine, and pale stools. Consider biliary disease. Other relevant history. Medications and alcohol. What remedies have been tried already and how effective were they? The lack of symptom relief with antacids in this case may indicate that acid is not the cause. NSAIDs and steroids can cause peptic ulcer disease. Warfarin and drugs that inhibit platelet function clearly increase the risk of hemorrhage. A high alcohol intake predisposes to gastritis as it is directly irritant to the stomach. Alcohol excess is also the leading cause of chronic pancreatitis in the UK and a risk factor for cancers of the stomach and pancreas, hence a detailed alcohol history is required in this patient. Past medical and surgical history. Is there a history of peptic ulcer disease or gastric surgery? In the past, partial gastrectomy with or without gastroenterostomy used to be performed for bleeding gastric or duodenal ulcers, and there is an increased incidence of stomal ulceration and carcinoma of the stoma following partial gastrectomy. Does the patient have a history of cardiovascular, cerebrovascular, or peripheral vascular disease? Arteriopaths may have ischemic intestinal pain. Are there any other serious medical comorbidities? Any major comorbidities may limit the choice of investigation for a patient, e.g. endoscopy is more risky in the presence of significant cardiorespiratory disease. Plan for investigation and management. After explaining to the patient that under normal clinical circumstances you would examine him, you would plan as follows. NB. Key investigations for dyspepsia. Ascertain H. pylori status by serology unless previously treated. Endoscopy allows biopsy and testing for H. pylori if indicated. Abdominal ultrasound scan. Routine blood tests. Check FBC for evidence of iron deficiency anemia. Liver function tests to aid detection of biliary disease. H. pylori serology, as long as the patient has not had previous eradication therapy. Consider measuring serum amylase for pancreatitis if the patient has suffered recent pain. Endoscopy. Any structural abnormalities can be visualized and biopsied. Biopsy of the stomach near the antrum can also be used to help detect the presence of H. pylori by commercially available urease tests. NB. No matter how likely the diagnosis of a benign cause, a patient over the age of 45 years with new onset dyspepsia requires investigation with endoscopy to rule out malignancy. Imaging. Upper abdominal ultrasound scanning allows imaging of the liver, pancreas, and biliary tree and is the radiological investigation of choice. It is best used for imaging solid organs, Fig 1, and gives little information on the stomach and small intestine unless there is marked pathology, e.g. gastric cancer causing thickening of the stomach wall. Remember that it is not infallible and can miss distal common bile duct stones and minimal changes in the pancreas. Other tests. If a biliary or pancreatic cause is likely, then CT or MRI scanning may be appropriate. If endoscopy is contraindicated, then a barium meal may be performed, but this can miss small lesions and does not allow tissue sampling. Management. Specific management will depend on the cause. For patients with functional dyspepsia, aim for symptom control, which often requires a combination of acid suppression and antispasmodics. Therapies that have been tried include proton pump inhibitors, antispasmodics, such as mebeverine, and antidepressants, particularly low-dose amitriptyline.